All right, well, good morning, and thanks to Sages for the opportunity to present on this topic. Oh. There we go, just firmer touch. All right, I have no disclosures. So one of the elements of surgery that I think makes our profession an art, as opposed to kind of rote technical practice, is the fact that surgeons continuously change and adapt their practice. Innovation is integral to the care of our patients. So if during a case we encounter a non-textbook anatomy or novel problem, we're required to innovate our way around the problem and get the patient through the case safely. And so whether we're conscious of it or not, most surgeons innovate every day as we kind of tailor therapies and operations to the intrinsic uniqueness of every patient and their disease. And I think the culture of surgery is really one that makes us continuously review and evaluate what and how we do things. I think I've yet to meet, and I think it's pretty rare to find a surgeon who, after years in practice, still performs operations the same way they did at the start of their practice. And how we evolve our practice is really based on our cumulative experience, our outcomes, whether they're good or bad, and new technologies that happen along the way. Innovation often dramatically moves patient care forward. A good example of this is the transition from open to laparoscopic, minimally invasive surgery. I don't think there's anyone here who would argue that an open Nissen fundoplication is better than an MIS approach in today's world. But we've progressed much further than this. Not only have we kind of transitioned to an MIS approach to Nissens, there are now several other safe technologies that we've developed to really address gastroesophageal reflux disease. So as surgeons, we really have three obligations for optimal care of our surgical patients. So first, we're actually obligated to know which new technology is out there and whether it's beneficial or whether it's harmful to our patients. Second, we're obligated to actually adapt and learn these new technologies and learn these new procedures if they've been shown to be of benefit to our patients. And then thirdly, we have a responsibility to provide our patients with unbiased, accurate, up-to-date information that's devoid of industry's bias, and allow them to be involved in decision-making in their care. When we don't do this, the results can be disastrous, right? For our patients, we can have complications, we can have poor outcomes, but it's also disastrous for us, right? It affects our well-being, and it can affect our careers. So we'll spend the next few minutes trying to talk about an entire field, not in an attempt to be comprehensive, but really just hopefully to kind of spark some reflection and spark some questions regarding your own practices at home as a surgeon innovator. So when we're talking about ethics, there might be this inclination to think, all right, yep, first do no harm, got it. What more needs to be said? But the origins of the concept of first doing no harm can be traced back to at least the 17th century, if not earlier. Yet there have been many instances where doctors have done great harm to those that we are supposed to serve. And so I think it's important for us to understand that and understand some of the things that have been put in place to prevent these events from happening again, but also for us to have an understanding that we have a personal responsibility to help prevent that harm. So what has been put in place? So in the 1940s, the Nuremberg trial of Nazi doctors who performed unethical human experimentation brought to light some of the worst of our history. And from that, the Nuremberg Code was put forth, and this really is about 10 points that kind of specified what constitutes legitimate and ethical medical research. Despite this code, in this country, the Tuskegee syphilis experiment ran for decades, where African-American men with syphilis were unethically studied without treatment, when of course there was treatment, in the 1930s until the 1970s. All right, so this led to the Belmont Report in 1978 and the Code of Federal Regulations. But I think it's important to remember that despite the creation of these regulations and the creation of IRBs, the effects of the violation of this trust, those effects still persist today in Black and underserved communities. So as we innovate and as we move surgery forward, with regards to the trust that we build with patients, we should remember that that's the most important thing, and that is the only thing that we must get right every time. Last point on history, so just to clarify some terminology, there's a spectrum of surgical innovation. On the one spectrum, there's practice, which the Belmont report defines as an intervention designed solely to enhance the well-being of an individual patient. On the other hand, there's research, which is designed to kind of contribute to generalizable knowledge. But in between there's this gray zone in which a lot of innovation can take place. And that gray zone holds both significant advances for patients, significant advances for society, but it also holds a lot of substantial trial and error and significant risks to our patients. So based on the literature, these 4 topics seem to be some of the main ethical considerations to think about as we think about incorporating new techniques and technology in our practice. And unfortunately, I can only really graze the surface of them. So first and foremost, how do we optimize safety? Well, the FDA specifically regulates this. They regulate new devices and technologies, and they approve their use in practice. And while their processes can be politically sensitive, they can be stringent, they also have the hard task of kind of reckoning with the idea that the safest possible introduction of technology for an individual may not represent the greatest societal benefit. So while the FDA is doing its challenging job, how do we directly keep patients safe? Because the FDA does not regulate procedures, right? It can only label products for specific use. Regulation is going to ideally be handled at the level of our local institutions. And so this requires a lot of transparency, a lot of accessibility from our local oversight committees. And it requires a lot of transparency from us individually as surgeons in terms of how we talk to our patients, how we talk to these oversight committees. And so I encourage all of us to think about whether we've ever used a technology that's off-label and whether we've had discussions with our patients about the risks of that, either before or after we use it, and whether we're talking with our oversight committees about that. Speaking of patients, so informed consent. So from the standpoint of the patient, surgical intervention represents both opportunity and risk. So patients may naturally kind of seek out the latest and greatest technology when they're faced with a chronic problem or a life-threatening problem. There's a lot of literature out there on informed consent for research and treatment, but there's much less on informed consent in the context of surgical innovation. But I think really the ultimate goal is that we should be striving to provide all of our patients, every single one of them, with information that is going to allow them to make an educated and voluntary choice for or against our treatment plans. And I think this graph really gives a nice visual to kind of highlight the point that the more serious the procedure, the more risk to the patient, the more information we should be sharing with our patients. In true emergency situations, we may not have the time to have long, extensive conversations, but we should absolutely be having those conversations after we innovate in an emergency situation. We should be having those conversations with the patient or the family. But usually when we're trying to innovate and do something new, it's not an emergency. So we should be setting out time in our clinics to have enough time to talk with our patients extensively. Our conversations should be very transparent and candid. We should be highlighting any differences in risks that may exist with the new procedure or the new technology. And I think we should make it known that the benefits of this technology or the benefits of the new procedure that we want to do, they can just be perceived. And while these are difficult conversations to have with our patients and it may make them feel uneasy with the level of uncertainty, I do think it lays a foundation of trust with our patients that's important, especially when complications arise. Moving on to training considerations. So how do we train surgeons in practice on new technology? How do we train residents? I think we often rely pretty heavily on organizations like SAGES to create training curricula, to create metrics of performance, to create benchmarks for competency. These are just some of the few that they've done. And I think just quickly, as SAGES and other organizations kind of take the lead in training and credentialing, we should really continue to prioritize putting diverse and committed surgeons at the forefront of this effort. So not industry. I think there's a role for industry, but industry, it must be limited. The surgeons really should be leading these efforts. Quickly moving on to ethical outcome tracking. So in the early 1990s, morbidity and mortality rates at VA hospitals were higher than the national average. As a result, we created NSQIP to kind of track outcomes in the VA healthcare system, and we saw significant decreases in morbidity and mortality. Subsequently, the ACS kind of followed NSQIP's lead and created its own validated program. I think these databases have been game changers, but when it comes to reporting on new technology and new devices, I still think there's several challenges. So first, we don't have a standardized reporting system with accurate CPT codes. That's going to be crucial to actually accurately assessing outcomes. And then, of course, we need to minimize discrepancies in reporting. So the discrepancies in who needs to report and who doesn't need to report essentially makes these databases just voluntary with no real oversight and no enforcement. So how can we hold ourselves accountable? What are some best practices? Well, in 2014, SAGES did put out some guidelines regarding just this, and in the interest of time, I'm not gonna go over all of them, I'll just highlight a few. And if my attempts to try something new with technology works, you should be able to just scan this QR code, and the SAGES guidelines should pop up on your phone if you wanna just look at them for yourself. They're actually excellent. So just quickly going through them, SAGES recommends that, of course, societies take the lead and that they provide timely assessments of new technology. When it comes to us as surgeons, we gotta be trained, so we have to complete relevant surgical training, and we have to seek out operative privileges, and that may be a laborious process, but that's the right thing to do on the affected organ system that we're working on. If we're just making minor, if we're doing minor procedures or making minor changes, SAGES recommends just to self-monitor your cases, self-monitor your outcomes. But if we're making sweeping changes in terms of how we're practicing or technology or standards of care, we really do need an objective assessment, and we should have monitoring from an external entity. And then lastly, we should be really comparing effectiveness, costs, patient outcomes, and safety outcomes to the standard of care or any other alternatives that are out there. And then just some quick points on how we can be successful in our own OR once we've followed these guidelines, and then once we've actually put in the work to bring this technology and this new procedure to our patients. You definitely want to build up to complex cases, do the simpler things first. Remember, teamwork makes the dream work, so discuss this with your senior partners, your colleagues, try to do it together. Talk to your OR teams ahead of time and let them know you're going to be bringing this new technology, this new procedure, so that they are not learning this in real time. You should be talking about it beforehand. And then set time, benchmarks, goals when you're getting started, just to avoid fatigue, frustration, and then, of course, most importantly, avoiding danger to your patients. And then lastly, really be disciplined with tracking your outcomes. So that's really the only way you can actually figure out, does this procedure, does this technology work for your patients? And then lastly, innovation moves patient care forward, and then hallmarks of responsible deployment of new technologies and new procedures really involves us taking time to critically understand the risks and benefits and how this can harm or benefit our patients. It involves us consistently taking the time to have transparent and unbiased conversations with our patients and involving them thoroughly in their decision-making process. And then lastly, we should be looking to national societies like SAGES just for timely guidance on accessible training and outcome tracking opportunities and technology effectiveness. I flew through that. Thank you, everybody.